All right, so like I said, welcome everyone. I'm Dr. Ken Zweig from Northern Virginia Family Practice. Thank you all for joining us. This is our monthly town hall meeting, and today we're going to be discussing dementia with Dr. Natasha Calo, and I will be introducing her in a moment, but I wanted to go over a couple housekeeping things first, if you all don't mind. First of all, you might have received already a text with a video from me, or if you haven't, you will in the next 24 hours or so, giving you another update on COVID. Just so you all know, unfortunately, we are now in another surge, if you weren't aware. Doesn't look nearly as significant as the one in January. We don't expect it to go to the same numbers that we had back then. And we don't expect the same number of hospitalizations or deaths anywhere close to what we had back then too, because we have such good treatment now. So if you are at risk, just be aware that we're in the middle of a surge. Make sure that you avoid big crowds or indoor spaces, wear your masks, and just make sure you're safe and vaccinated. Also be aware that the FDA just approved yesterday a booster for the 5 to 12-year-old range. So anybody 5 and up is eligible for a booster if they've already finished the first vaccine series. So please go ahead, and if you have young kids at home, get them boosted. That'll help prevent spread, and that's the most important thing. Kids don't usually get that sick from COVID, so it's not going to prevent many hospitalizations or deaths, but it will prevent your kid from getting COVID, or at least decrease the risk very significantly, and also keep them from staying out of school, preventing it from getting spread in schools, and preventing them from bringing it home to you and your family and relatives. So everybody hopefully can do their part by getting yourself and your kids vaccinated and boosted, as they do work, and the numbers show that they work. Also, we wanted to introduce our newest member of the Northern Virginia Family Practice team, Dr. Christy Castillo, who has just joined us, and we're very excited to have her as part of the NVFP team. So I was hoping Dr. Castillo would say a few words to introduce herself.
Hello, everyone. It's my name is officially Maria, but I go by Christy Castillo Catoni. I am new to Northern Virginia Family Practice. This is my 3rd week there, but I have been practicing in the kind of Northern Virginia Alexandria community for a little bit over 9 years. So I have strong ties there. I'm so excited to be joining. It's such a wonderful team to work with, and I've already met a few of you, just kind of seeing you for acute visits, and the patients are lovely. So you will see me around. Please feel free to stop me and say hi. And I look forward to working with everyone.
Great. Thank you. We're excited to have you here. So yeah, feel free to stop by and say hi to her. And for the main event tonight, we have Dr. Natasha Calo. It was very funny, actually. Just earlier today, I was looking for Dr. Calo's contact information in my phone, and I found an email when I was looking through from 2010 to her, inviting her to my practice, which at that time was in Ballston, to talk to us about dementia. So in true fashion for dementia, I forgot that I had done that. So I think that speaks to what we're going to talk about tonight. But anyway, so I've gone to this well before, and so I'm happy to have her back to talk about the same thing. So Dr. Calo is originally from Russia, where she was born and raised, and she earned her medical degree at Moscow State University, and then moved to the US, where she finished her residency at the prestigious Baylor College of Medicine in Houston. She's been practicing in Northern Virginia since 2000, which is about the time that I started as well. And that's how we got to know each other. We both started at the Virginia Hospital Center. She currently holds an academic appointment at Georgetown University, where she regularly speaks on neurologic topics. And she has been recognized by the Washingtonian Magazine and Consumer Checkbooks as one of the top neurologists in the area. So thank you very much for coming, Dr. Calo. We're excited to have you and hear what you have to say about all things dementia and memory, and take it away.
Thank you, Ken. A couple minor corrections. It was Moscow Medical Stomatological Institute, not university, because when I was there was no medical school affiliated with university. That has obviously changed. And I have an affiliated position with Georgetown. It's more in liaison, but I'm honored to have it. I have been in Northern Virginia since 2000, and it's a long time.
Thank
I'm
you.
now part of integrated neurology services. I practice with Dr. Fishman, Dr. Schumann, our pain doctor, Dr. Klein. I have personal interest in Alzheimer's disease. My father passed away with Alzheimer's. He was in his late 80s. He did not take that disease lightly. He was a mean, cantankerous old man. He didn't follow my advice, at least not all the time. He was in Russia, which made it very difficult to take care of him, but also made it easier because caregiving was much cheaper than it was here. He also didn't follow my advice on recommendations about heroic measures and end of life and what to do and what not to do. He wanted to do everything. His wishes were well known to me and I followed those. My wishes are well known to my family and they know to love me, but not to love me too much. They will know what to do. And I will encourage you to talk to your family members about what needs to be done, what does not need to be done to absolve them of the guilt, which invariably comes with the end of life, whether it's Alzheimer's disease or something else. Even knowing that did not spare me the guilt because I thought I could do more. With that being said, Alzheimer's disease is a very common condition. By the time somebody is in their mid-80s, the chance is about 50-50. People always ask me, what's the difference between Alzheimer's disease and dementia? I always tell them that dementia is memory loss. You tell me you have memory loss, I say you have dementia. We just put medical labels on things so we can communicate to each other and in shorthand convey what needs to be said. There are many causes of dementia. It can be caused by strokes, it can be caused by injuries, vitamin deficiencies, and so on. Alzheimer's is just the most common cause of dementia as people age. People also tell me, oh, everybody at my age forgets. And I tell them, certain things become more common as we age. Blood pressure is a common thing as we age. It doesn't mean it's normal. Cholesterol, high cholesterol is a normal thing as we age. Doesn't mean it's normal. Same with the memory loss. It's common, but it's not normal. Again, in the mid-80s, the chance of Alzheimer's disease is about 50-50. It is not zero before that. It's not 100% after that. And it appears that if you have families with longevity, families where people don't die from heart disease or cancer at an early age, there's a lot of family members with Alzheimer's disease. It may be simply a reflection of the fact that your family is healthy and has good genetics otherwise. Do I worry about Alzheimer's disease because my father had it? Not because of that. I worry about Alzheimer's disease because my family has pretty good longevity, and I think I might live into the years when it may become a real issue for me. Just because you have family members, you should necessarily worry about it more than the next guy. The number of families where we have a known genetic cause for Alzheimer's is less than 1%. And they're the ones who have it in the middle age or even younger. And those families are researched and investigated and part of all kinds of programs in major academic institutions. At an older age, it's more, do I live long enough? And how good is my luck or how bad is my luck? But it doesn't have to be hopeless. It appears that controlling vascular risk factors, blood pressure, high cholesterol, diabetes, sleep apnea is important to reduce the risk of Alzheimer's disease. Dr. Zweig just told me that the sleep disorders are his passion. And it's very important to treat sleep apnea for many reasons. People kind of put it aside from blood pressure, from diabetes, from cholesterol, but we lump it all together. So if you control those risk factors, your chance of Alzheimer's disease decreases. It's never going to be zero, no. The other important thing you can do for yourself is regular exercise. It's good on many levels. Your knees and hips, your back will thank you. Your weight is going to be better controlled. You're going to feel better overall emotionally. The depression might get better, but it also reduces the risk of Alzheimer's disease. Your diet is important. It doesn't have to be the latest fad. Not everybody needs to be on a gluten-free diet, although there's nothing harmful about that diet. And people who suffer from celiac disease and gluten sensitive people benefit from a lot of people jumping on that bandwagon because the choices are plentiful now for gluten-free meals. But healthy amount of fruits, vegetables, fish, small amount of alcohol, and for healthy women, 1 drink a day, for healthy men, 2 drinks a day. Those have to be regimented drink. 1 martini at a bar is not 1 drink. How do I know? Because I can't have them anymore. They put me to sleep. A small glass of wine is a good thing, it's a beautiful thing. But if you drink in excess, that it can actually increase the risk of Alzheimer's disease. If you have other health issues, you may not be able to drink at all. Talk to Dr. Zweig about it. Yes.
May I just clarify that? So what we define as 1 glass or 1 drink is a 12-ounce beer at about 5.5%. That's Budweiser, not the stouts or the heavy things that they have now. A 6-ounce glass of wine, which is usually much smaller than what most people pour or what they pour at a restaurant, or 1 to 1.5 ounces of hard alcohol. So those are what we define as 1 drink. Usually they tend to be more by most people. So don't just say, hey, I had 1 glass. You want to measure those so you know what you're actually having, because it does make a difference.
Thank you. Thank you. So healthy lifestyle, control of risk factors. Don't be afraid to go to your doctor. I'm not going to judge you if you don't take your blood pressure medications. I'm going to gently remind you to do it. I'm going to re-prescribe them. We're humans. We're not perfect as well. When my dentist asks me how often I floss, I say every day, twice on Sunday. I probably should be more precise about that, but we don't judge you. We really want you to get better because we're humans too. What happens if somebody starts to exhibit memory problems? The important thing is to bring it to your healthcare professional's attention right away. It may or may not be Alzheimer's disease. Other things can contribute to memory loss. Strokes, very worrisome. Sometimes a small stroke or constellation of small strokes can cause memory loss without any other symptoms. Thyroid disease, I always say, oh, it's easy to treat, but I'm not the one treating it. Dr. Zweig is treating it, but there are medications to treat it. B12 deficiency, folic acid deficiency, really easy to treat. Even I can do it. You can take your oral medications. I can give you B12 shots. Now, people always ask me, and even if their blood pressure is normal, would B12 shots help? Well, not so much with memory loss. I will leave it up to Dr. Zweig if it helps with level of energy, sense of well-being, or any other conditions. What do you think? What should I tell my patients about that?
I underwhelmed with that.
Fair.
So unless you have known B12 deficiency or risk for B12 deficiency, then certainly it's worthwhile. But for just the average person who has normal B12 levels and no risk for it, I haven't seen good data or personal experience with my patients that really helps all that much.
I feel the same way, but if B12 is low, normal, or deficient, replacing it might help a little bit. We always do a brain scan, usually an MRI, for 2 reasons. MRI is much more detailed than a CAT scan. Also, it comes without any radiation. It's a safer test and much more informative. If it shows strokes, we'll deal with that. If it doesn't, kind of points more towards Alzheimer's disease. That's another common question. Can you see my Alzheimer's on MRI? No, I cannot. As we go through life, just like we get wrinkles and white hair, the brain shrinks. There's atrophy. That's a fancy word. You say brain shrinks, I say atrophy. And there are white spots in the brain. We call them non-specific white matter changes. Everybody has them. And if you compare many patients with Alzheimer's, they'll have more atrophy than people without Alzheimer's and more white spots. But an individual person, you cannot make that diagnosis based on MRI. MRI rules out strokes. There's a special scan called PET scan, PET. It's a nuclear scan that can be very helpful. Unfortunately, Medicare does not cover PET scan and it can become pricey. In our practice, this is the 2nd time we've had a special grant from Medicare that allowed us to do PET scan. The test is not experimental, the coverage is. So what Medicare is trying to do is determine if it's helpful for Medicare beneficiaries. I have a feeling that it will be covered in the near future because it was very helpful to diagnose somebody where we were not sure, to undiagnose somebody where we're not sure, and in some cases to convince a person that they actually have Alzheimer's disease and they need to be on treatment. But we'll see. For now, it is difficult to get and it is pricey. There's also neurocognitive testing, and that is covered by Medicare. It's a bit tedious, and sometimes a person of dementia does not like it because they feel that they're failing it. But pretty much everybody is failing it. They push you to the point that you feel you're going to fail because they want to know what your capacity is, but that's tedious. Even without PET scan, even without neurocognitive testing, we are able to diagnose Alzheimer's disease. The question is, okay, you diagnose Alzheimer's disease, and then what do you do? Well, we have treatment. The treatments, the medications we have now, they're not perfect. They slow down progression of memory loss. Your memory doesn't get better. Progression doesn't stop, but it's slower compared to somebody who doesn't take the medications. And it's very frustrating. I give you migraine medications, headache is gone. Dr. Zweig gives you blood pressure medications, numbers look great. With Alzheimer's disease, memory is going to continue to decline, but it's going to decline slower. The person is going to have more time where they're good. They can participate in family activities. They remember things. And yes, it's not going to end well, but it's not going to end well for all of us. What we're trying to do is to have more of the quality time, whether it's physical health or cognitive health, to have more quality time with our families, with our hobbies, with our travels, whatever it is that we want to do. The other important thing about diagnosing Alzheimer's disease is planning. Planning is important even without Alzheimer's, but sometimes it takes a possible serious diagnosis for us to plan for the future. What's going to happen with your wealth? Where do you want it to go? Who is going to be making your decisions, your health-related decisions when you cannot? And what do you want to do and what do you not want to do at the end of life? It's important to make those decisions when you actually can do it yourself. For my husband and myself, it took the pandemic to have the will. And we have a blended family. So if something were to happen to us, unfortunately, nothing has happened. I don't know how nice and smooth it would be. We also wanted to make sure we know who's going to take care of our health if need be. So it's important whether you have Alzheimer's disease or not, but especially if there's a concern about memory decline, that's doubly important. I don't necessarily talk to people about the planning, but Dr. Zweig, do you? Because I think you guys routinely do that.
Try to regularly. Yes, certainly at every physical. And thank you for bringing that up too. I think it's a wonderful point and really important. Alzheimer's aside, just I think you should do it when you're feeling well. When there is no problem, that's the best time to do it, because that's when you're thinking clearly and that's when you can have good conversations and you're in your right mind. So I think that's something you should bring up before any real medical problems hit. You don't want to wait till it's too late. So thank you for bringing that up. I think it's a really important discussion.
And in those matters, there's no right or wrong answer. Like my father wanted everything done, which was completely against what I believe should happen. I probably want to have less done than most people, but there's no right or wrong answer. But what you do, you absolve your family of the guilt at the end of life. But back to treatment, we have basically 3 medications. One of them, the original one, called the Donepezil, that's generic name, or Aricept, which is a brand name, was introduced 20 plus years ago. It's an oral medication. There are 2 doses, 3 to be precise, but the third one is never used, 5 and 10 milligram. 10 milligram is the target dose. It can cause stomach upset, but that's about the only side effects that we see regularly. If that happens, we move to the medication from the same class called Exelon or Rivastigmine. It's a patch. It's not any better or worse than the Donepezil, but because it's a patch, it can be better tolerated. It decreases those GI upset symptoms. And we start with these meds. Hopefully, it can be one of them. And after that, we add second medication called Memantine or Namenda. We don't substitute, we add. That one is usually very well tolerated. And if somebody cannot tolerate one of the first ones, well, they can be on Memantine or Namenda alone. I see a question about galantamine. Yes, That's another medication from the Napizil and rivastigmine class. It's an oral medication. In terms of tolerability, it's very similar to the Napizil, but for some people, it is better tolerated. So there's the 3 in first class and Memantine in the second class. And don't ask me about the infusion, Aduhelm. It's a developing situation. It's a fluid situation. I do have 2 patients who get the infusion. One of them has a commercial insurance. The other one has Medicare. And Medicare is changing the rules as we go in terms of who can and cannot get the infusion. We'll have a better information. Also, there's a risk with this infusion that the junk that we accumulate with Alzheimer's disease, for the lack of better words, as we clear it, can develop bleeding. And what happens, you have to have 4 MRIs. When the medication came out first, you were supposed to have 2 MRIs in the first year of infusion. Now you're supposed to have 4 MRIs. So where we're going to end, I don't know. And those are medications that slow down progression of memory loss. But in the same class as Aduhelm, I have a feeling we're going to have an explosion of the treatment options. It's always difficult to be first. There was a medication before Aricept, Tacrin, I believe was the name. It had to be taken 4 times a day, and there was a risk of liver failure. Obviously, that did not last long, but it was a trailblazer. Now we have better options. So hopefully with Aduhelm, we're going to learn what to bring and what to not to bring to the actual clinical practice, how to do it, and hopefully there will be safer options and more effective options in the future. I saw a question on the screen about medications for prevention of Alzheimer's disease. Several medications from what I mentioned were tried in patients with what's called mild cognitive impairment. It's when your memory is not as good as it used to be, hasn't amounted to dementia. None of them were effective, and one clinical trial had to be stopped because there was some worsening in the treatment group. Whether it was a random chance or true worsening, there was no improvement, and so the study was stopped. So there's no preventive treatment. It's the lifestyle and treatment of vascular risk factors for prevention. Disease goes on for years. Namenda is Memantine, by the way. I see that question on the screen. Disease lasts for years, sometimes decades. It's a slow, very slow progressive disease. There are patients who are outliers. There are patients who stabilize on treatment and don't progress year after year. There are patients who progress very rapidly, but it's a very slow progressive disease. If I see patients who decline slowly and suddenly they're much worse, something else is going on, I always ask them to see their primary care physician, ask them to see Dr. Zweig to make sure that they don't have urinary tract infection, that they take their other medications properly, that they're not dehydrated and not something else medically is going on, because Alzheimer's disease is a slow progressive disease. People always ask me how long? How long to what? Till you die, or how long till you cannot sign your name? I don't have answers to that. After the first few years of memory loss, you can kind of see the trajectory. The past is usually prologue for the future with this disease, but nobody knows what's going to happen. It also depends on what else is going on with your health. Just because somebody has Alzheimer's doesn't mean they're not going to have heart attack. Doesn't mean they're not going to develop cancer. And with COVID situation, we saw that the older, vulnerable population, much higher risk of death than anybody else. And dementia did that make them more vulnerable, either because of the dementia itself or because people tend to live in crowded situations like assisted living, memory units with caregivers coming and going. So nobody can predict the future. Today is going to be the best day of your life if you have dementia, because tomorrow it's going to be a little bit worse, and then a little bit worse, and then a little bit worse. And there are still many faculties you can enjoy. There are many faculties we can enjoy as aging adults. We may not be able to run marathon, but we can go for a walk. I'm talking about physical things now. You may not be able to crochet for 10 hours a day like you used to, but you may be able to do 30 minutes with your arthritic fingers. So today is going to be the best day of your life. And I'm not just reminding everybody else, I'm reminding myself about that. Ken, anything else I have missed? Anything else we need to talk about Alzheimer's disease? Maybe some questions that
Actually,
came through that I
I
missed.
personally have a number of questions that I think would be good for people, and there's also some questions that people have brought up too. But one thing that I thought would be helpful is that I've always heard and learned, one thing to understand is that, as you said, it's a slow and long process, but it starts long before anybody has any symptoms. So, in your 40s, even, or 50s, is when you need to start making the changes, because it can be going on for 20 to 30 years before you start noticing that you're having any symptoms. And so that's one of the reasons why the treatments are so hard, is because by the time you are losing your memory to the point where it's actually impacting your function and people are noticing, you're so far progressed that it's really hard to pull that back. So really anything that's going to be worthwhile is going to happen many, many years before. And so I don't know what you think about that, if you agree with that, but that's always been my understanding.
Absolutely. And for the reasons, many reasons, not just dementia, your blood pressure, your cholesterol, your diabetes, your level of pain often depends on what your lifestyle is in your middle age. I am 55, and in the past year, I've lost significant amount of weight because my blood pressure started to go up. And all this time I was like, oh, I can eat what I want, I can do what I want. Well, that's a carryover from my youth, from the year 2000, where we started to practice in Northern Virginia, and that's not youth anymore. Yeah, one day I said, oh, I'm middle-aged, I shop at Chico's. You may not know what that is. It's for the ladies. Yeah. And I've realized my blood pressure is going up. Am I ever going to be medication-free and have normal blood pressure? No, but I can delay the need for the medications, reduce the need for the medication, and improve my overall health. Improve my pain level, for example, because none of us are pain-free as we go through life. And of course, it's important for dementia as well. So I completely agree with you. It starts much earlier than you think you need to take care of yourself.
Right. Yeah, so it makes a difference, as with every other disease. Yeah, right. So we always say. The other thing is that I think this goes to the other question that somebody had was, are there any medications for prevention? We always see ads and commercials and pop-ups and everything on our computer about supplements to prevent dementia. Can you speak to that, please?
I'm not sure. Those supplements are not FDA evaluated and approved. It is very easy to make a claim, run a study that's not as rigorously controlled as the studies that FDA evaluates. For example, we now have a study for a medication that's approved for another condition that we're part of. It's going to go for over 3 years. And there are very strict inclusion criteria. We screen people. A lot of them failed that screening. With the supplements, there's no rigorous testing like that. So claims can be made that may or may not be accurate. And it is very expensive to do proper studies. So those claims may not be tested to the point that you can rely on that. The best I can say that supplements are probably not harmful, but again, it's probably, nobody knows for sure. Something like a multivitamin and vitamin D, and correct me if I'm wrong, I think is important for most of us to take. Multivitamins just because you never know what that lettuce salad is missing, right? And vitamin D because I hope you're using sunscreen and limit your sun exposure. But short of that, I do not recommend supplements. If my patients want to take supplements, I usually don't oppose that. Although there are some medications that can interfere, some supplements that can interfere with prescription medications like blood thinners. So I would be very careful if somebody takes those. What do you tell your patients?
So the biggest thing I say is that, yeah, I agree with the vitamin D. Certainly, I think we just don't get enough vitamin D in our diet, but that mostly the American diet is not deficient in almost anything. We get more than enough of just about everything. So a multivitamin is no harm, and that's certainly fine to take if you want. I'm not convinced that it's actually necessary for most people, but for some people it is worthwhile and probably no harm. But the biggest thing for any supplement is just to be aware of where you get it. There's no regulation, and there's lots of evidence that if you get it from some questionable sources, that there is a lot of impurities. You may not be getting getting what you think you're getting. You can have a lot of things like lead and mercury and cyanide and a lot of other really terrible things that are in them because it's not regulated by the FDA. Nobody's buying in the store. So if you get a supplement, make sure you get it from an American manufacturer and a national chain store like GNC or CVS or Whole Foods or Safeway, because they do their own internal monitoring. So just be careful about where you get your brands. Give it a try. And if you're trying to get it for a reason that makes you feel better and makes you feel better, keep taking it. That's fine. But just be aware that you're not always getting what they tell you that it says on the bottle.
Yes, well, one of the advantages of supplements is placebo effect.
Sure.
Placebo effect is real. You see it in certain conditions, for example, migraine treatment, placebo response is very significant. It's not zero, even in conditions like cancer, and definitely not in Alzheimer's disease, because if you think you're doing something helpful, you feel better. And honestly, that's a big part of your life, how you feel. Yes, your memory is going to decline, but it's going to decline even with what I do. Even with the best medication I have, your memory is going to decline. But as you go through life, as we all decline physically and cognitively, if we feel well, that's very important. And I never underestimate placebo effect.
Absolutely. Oh, I think
in addition to the clinical effect that I'm hoping to achieve.
Oh, absolutely. If I could prescribe a placebo, I always say I'd be the greatest doctor in America. One other question from me that just to clarify, and then we can get into some of the questions that were on here too, though. If you could just explain the difference. We had talked about, the title being, where did I put my keys, and say that's sort of tongue in cheek, but obviously there's a difference. The joke is, if you forgot where you put your keys, that's one thing. If you don't know what your keys are for, that's another. There are different kinds of memory. So if you could maybe explain in a little more detail what we mean by memory loss, kinds of memory loss that are concerning versus just sort of natural forgetfulness that we even have in your 20 or something like that. And when should people be worried about it actually being a problem?
It's a very good question. So we all know our baseline. We all know our baseline, and our family members and friends that see and interact with us regularly know our baseline. What you're looking for is changes from that baseline. If you forget your keys 3 days out of 5, when you go to work and you come back and you get your keys, that's fine. But if you never forget your keys and it happens 3 days out of 5, that is a problem. If you drive to see your family member and you do it once a month for 10 years and you end up in the next town, that is a problem. I have a patient who was found in North Carolina. She drove, I don't know what car she had, but she drove from Northern Virginia to North Carolina because she was lost. She did not know where she was going. She stopped when she ran out of gas. And that's the first time her family members realized, oh yeah, she was forgetful. Yeah, but that was a real red flag. That happens. If somebody starts to have car accident, that's especially concerning. When you look at somebody's pill box and it's full on Wednesday and Monday and Tuesday pills were not taken, that's concerning. When your check bounces, that's concerning. So when there are changes from the baseline, especially with the important functions like taking medications, writing checks, if there's a change, bring it to your doctor's attention. There's no harm in that. There are clear cases of dementia. When we do studies and medication, tests and medications, there are borderline cases when I'm not sure, just like you said, is it normal forgetfulness? Where's my keys? Where's my head? Right? When is my grandchild's birthday? I remember my wife's birthday, my son's birthday, my daughter-in-law birthday, but not my grandchild. Is that normal? I don't know. That's when we can go further and do that detailed neurocognitive testing to tease out just benign forgetfulness, senior moments versus real dementia.
That's very helpful. Great. All right. And some of the other questions that people wanted to know is, first of all, do you have any resources for support systems in the Northern Virginia area for family members that have relatives going through dementia?
I'm not sure. With the COVID, a lot of things have changed. But with the COVID, a lot of things have changed. And so any support groups that are online can be accessed from anywhere in Northern Virginia, Alaska, Texas, any place you want. A good place to start is alz.org, Alzheimer's Association. They have resources, recommendations, very high quality information. If they endorse something, they know why they're doing it. It's a good place to start. Whether I know about a physical place, I don't. I welcome all information from participants. Maybe they know of some actual physical groups to support.
And I think I misspoke. I said support groups. They said support systems. So I got the impression that maybe they're speaking to visiting nurses or something that can help with taking care of the person at home.
The best place to start is Agency on Aging. Each county has it. And they have resources you cannot even think of yourself. There may be many resources for a particular person. There may be a few. It depends on the level of income. It depends on health insurance that you have. It depends on where you live. But that's the best place to start. A lot of services that are actually needed, like taking care of somebody, giving you respite care, are not covered by Medicare. They're covered by long-term care insurance. And the time to get that is in your youth or middle age. It's almost impossible to get it when you're older, and definitely impossible once we're talking dementia. They cover help at home, they cover bathing, changing, etc. Medicare does not cover that. But that's another very important part of the planning. On the other hand, your local resources, your local social worker, Agency on Aging, may have county resources that you've paid for all your life with property taxes and so on, those gas taxes that can be available to you. So fall back on that first.
And we also encourage you to reach out to your primary care doctor, reach out to us. We know people in the area that can help with that as well. We have some connections. We can't help with payment, but we can help with reaching out to people who we've had experience with who we think are good in this area. So. Another question was that my mom has frontotemporal dementia and Parkinson's. It's a tough combination. And she wants to know, is there anything that anybody can do to help her? She's taking Namenda.
Well, I don't know your mom's particular situation, but in general, there's no specific treatments for frontotemporal dementia. Namenda, Memantine, is what we use for Alzheimer's disease, and because it's a very benign medication, a lot of physicians prescribe it for frontotemporal dementia. It's a more rare case. The main issue usually is behavioral, and that's usually treated with medications like SSRI, antidepressant medication. Prozac is a well-known example of that, but there are many more in that class. Parkinson's disease has a lot of medications used for treatment. New ones are coming. That can be symptomatically managed quite well for a number of years. But for frontotemporal dementia, there's nothing specific right now.
Thank you for that. And somebody wants to know, why would somebody change from Aricept to Namenda?
Aricept and Namenda have two different mechanisms of action. We love using those in combination. When I would switch, again, I don't know specifics of the person where it was switched, or maybe it's a hypothetical question. I would switch if somebody has side effects with Aricept. If they don't, I would keep Aricept on board and add Namenda to that. If I start them with Namenda, I'll keep Namenda on board and add Aricept to that, or I would add Exelon or Galantamine, one of those medications in combination with Namenda.
Do you recommend a particular diet to help prevent dementia? Or what they're saying?
I think you're better equipped to speak of that. I think generally Mediterranean diet, fruits, vegetables, fish, nuts, walking around and riding bicycles instead of cars.
Things that prevent everything.
Good one. Yeah. But what do you recommend?
All the same. What's that?
Yeah. What do you recommend in terms of the diet?
I agree. Yeah, absolutely. Just, fish, fruits, vegetables, recognizing what you're eating, whole foods. I'd also like to hear what you think about carbs and their role in dementia. So obviously, I've heard that there's a lot, having high carbs, especially high processed sugars, specifically, especially in diabetes, can hasten the onset of dementia.
What else are people asking?
So there is one person asked, I noticed spatial changes in my husband. Could this be dementia? I'm not sure what they mean by spatial changes. But,
I'm not sure, but I think it may be coordination.
coordination maybe, yeah. Mhm.
It can be part of dementia, especially if they have other difficulties like remembering things or high executive functions, paying bills. In itself, coordination problem is usually something else, but that should be enough to bring it to somebody's attention.
Agreed. Are you aware? I've been hearing for a long time about a vaccine for Alzheimer's, and they've been talking about it. It's been a long time, and I don't know if you've heard if they're any closer, if that's something that is a realistic thought.
I haven't heard that they're closer, which I may or may not be privy to that information, but there was one clinical trial of the vaccine that had to be stopped because people developed inflammation of the brain, encephalitis, and it was a no-go. It was stopped early on. But again, it may be a trailblazer for further interventions. I'm surely hoping that there will be something when I need it.
Right. Yeah. So, or sooner than later, because we're in the point right now where we need to stop it now before it's too late. Yeah.
Yes.
And one other last question is, I've also heard the concept that if you live long enough, you will get dementia. It's maybe it's 120 for some people, and you just never find out. But that there is some concept that it's progressive just through age, and that if you live long enough, you will get it. So as you said, having longevity in your family puts you at higher risk. Do you think that's true?
I use that phrase often, actually.
Is that true? Okay.
Because while the risk is about 50-50 in the mid-80s, it's less before and it's higher after. It is progressive. It doesn't plateau. In the 90s, first of all, there are very few people who live to be in their 90s. And out of those, there are very few who are well, who are healthy. Most of them have health issues, whether it's physical health or it's cognitive difficulties like Alzheimer's. It gets harder and harder to find a healthy person at that age.
No, you're right. I probably heard that from you at the last talk in 2010. So,
you remember that?
I remember that, exactly. That's good. It's still there. And it looks like one last question we have is, can you speak to other causes of non-dementia memory loss, such as sleep, depression, stress? Are there other things that you could be seeing? We talk about medical things. Are there any things that we could be doing that are causing memory loss that aren't dementia?
So technically memory loss is dementia, but there's something called pseudo-dementia. When somebody feels that their memory is decreased and they act like their memory is decreased, but it's related to the mood disorder, to depression. It slows you down. It's like you're walking through water. Your brain is not functioning. The reason it's called pseudo-dementia is not because it's not real. It's very much real. But because once you treat depression, memory restores to its normal state. So it's somewhere there. It's dormant. It's hibernating. It's affected by the mood. And once the mood is restored, the memory improves as well. So that would be a non-dementia memory loss.
And I would also go back to what I had said about sleep. That poor sleep and sleep deprivation would be the same thing, that if you only get 5 hours of sleep, you have slow retrieval, difficulty making new memories, and your memory just doesn't function as well. But if then you end up getting more sleep, your brain's going to work a lot better, and you'll be able to retrieve those memories and have the same type of issue. But chronic sleep deprivation certainly plays into this, and so I encourage everyone to get at least 7 hours every night.
Absolutely. And on top of that, if somebody has sleep apnea, they actually increase the risk of dementia. Not just, your memory is so-so because you didn't sleep enough. There's an actual physical risk of increased dementia. That's always telling patients there are two reasons to treat sleep apnea. One is to make you feel better now, because I think it's very important. The other one is to prevent risk factors in the future, hypertension, lung problems, dementia, strokes. sleep apnea can do all that if untreated. Don't think, oh, you're not sleeping well, that's it. That's not it. It's your future right there.
And that's one thing that with all these things, exercising, eating right, they may not make you feel better immediately in the moment. There's no immediate gratification, which is what makes it so tough. But you get the extended gratification of feeling better, living, not just living longer, but feeling better, looking better, having more energy, and being smarter, being able to be more present. And, it all adds up. So eat right, exercise, get enough sleep.
No, wait a second. What about my business? You're taking away from my business.
Sorry, and mine as well. Yeah. I could use a little more free time. I'm okay with that.
Yes.
Great. If there's any more questions that anybody has, please put them in the chat. Actually, somebody did ask about exercise in middle age helping to prevent dementia. We did discuss that, and yes, certainly it does. Absolutely, good aerobic exercise can certainly help.
It is not just dementia, aches and pains.
Aches and pains. It helps with sleep, helps prevent heart attacks and strokes and high blood pressure. Yeah, just it comes down to three things. Yeah. So, well, this was great. If any other questions, doesn't look like any of them come up. So thank you so much for your time. This was wonderful and very helpful. Hopefully you all will remember what we talked about here today. And if you have any questions for us at Northern Virginia Family Practice, feel free to email them to us, and we can pass them on to Dr. Kalo if they're specific for her.
Absolutely.
If you're worried about a particular case you have, you can talk to us and we can get you in touch with Dr. Kalo if needed, but we really appreciate your time, and this was very, very helpful and educational.
Thank you, it was a pleasure. Hopefully we'll do it again.
Thank you, I hope so too. All right, have a great night, and hope everybody has a wonderful evening. Take care.
Take care.
Bye.